afternoon, everyone, and welcome to this Sunday's version of Black Health Trust. We're so happy that you have chosen to spend some time with us as we explore this week's breaking issues and announcements regarding COVID. We are brought together by our founder, Dr. Randall Maxey, as an effort to provide credible information to communities of color. Without further ado, I turn it over to Dr. Maxey.
Thank you very much, Dr. Neighbor-Stevens, and thank you, Dr. Ivan Walsh, for joining me as a co-moderator, Dr. Jocelyn Hines, and of course, Dr. Barbara Neighbor-Stevens. We have a major treat for everyone today with our featured person to answer questions. But first, I'd like to start with a slide. Simon, if you can put that slide up for me. So the Black Health Trust, we pride ourselves on providing vetted information that you can have confidence in. We do not purport to give medical advice, but we do encourage you to listen to us and take a subject up that we present with your personal physician or healthcare provider. So in this first slide, which I imagine will come up in a moment, we have a new emergency use authorization by the FDA, and it is for the Pfizer BioNTech vaccine. And that is for the emergency use authorization. It was authorized for children as young as 5 years old. It's the first in the US to be authorized. And one of the reasons that it was authorized is that more than 39% of the young people being admitted to hospitals are people that have not been vaccinated. And that's a concern. These statistics around this EUA showed that there was 91% efficacy of these vaccines. So our speaker this morning that we're going to have answer some of our questions is Dr. Oliver Brooks. He's the past president of the National Medical Association. He graduated from the absolute best medical school in the entire country, Howard University. He is the chief CEO of the Watts Health Center and Health Plan, and he was also the chief medical officer and chief of pediatrics. Dr. Oliver Brooks, welcome to the Black Health Trust. We know you've been with us before, and if you'd like to give a few statements on the new vaccine, and we do have questions for you, and thank you for bringing your expertise to our communities of color. Dr. Oliver Brooks.
Thank you very much, Dr. Maxey, a good friend and colleague, past president of the NMA and nephrologist extraordinaire. I do, first of all, appreciate Black Health Trust and the weekly webinars and the sharing of information. It's really important that information is provided about us by us. So as it relates to the new recommendation of significance, it was granted EUA, emergency use authorization, by the FDA. However, the ACIP has not met yet. The ACIP will be meeting on this on November 2nd, which is 2 days from now. And from that meeting, the formal recommendations will be released based on the vote of the ACIP. So the vaccine has received FDA authorization for ages 5 to 11. There are approximately 20 million children in the US that are ages 5 to 11. There are 8,300 cases to date with about 150 deaths. So the death rate and the infection rate is not, 18 8,300 hospitalizations, excuse me, not cases. So there are hospitalizations. Another concern with children, as you all know, post-infection, which is a reason why we don't want them to get infected, is MIS-C, multi-system inflammatory syndrome in children. Of note, higher incidence in Black children. So higher incidence of everything in Black children, just like Black adults, except the good stuff. We have lower rates of good things, like immunization coverage is a great example. National Immunization Survey has shown persistent disparities in Black children's immunization rates. So I believe I'll stop there, Dr. Maxey, and to your moderators, and just kind of open the floor to questions and provide any information that I can.
Well, our resident moderator, pediatrician, I'm going to give the first shot or first question. Dr. Nabors-Stevens.
Well, thank you. I want to start off with the general question that all health providers, but pediatricians in particular, need to be prepared to respond to in the days and weeks coming. And that is, why should parents allow their children to be vaccinated against COVID-19?
So again, there are hospitalizations and deaths, though the rates are low. I will start my answer with saying that the vaccine, and we're specifically referencing for children 5 to 11, the Pfizer vaccine, Pfizer-BioNTech vaccine, it's safe and effective. Children, even if they don't get sick, hospitalized, or die, are a reservoir for the virus, so they can spread it to others. To get to protective status, which I'll call herd immunity, or I like the term community immunity better, we need somewhere between 80 to 90%. So that's a full vaccination, not the adult vaccination. So if we get to herd immunity, we have to get these children vaccinated. I think an important concept also to remember is that if these children are unvaccinated, they're more likely to get COVID-19, and then they will miss school. And so these children have had major issues with their learning structure since COVID. Children, I believe, I don't know if the studies show it, but I believe it don't learn as well in this environment of remote learning. So those are some of the main reasons: the infection itself, the secondary effect of potential missing school, and then spreading it into school, and then the fact that they are a reservoir for the virus to spread it to the adult population.
So we haven't talked about what's actually in the proposed vaccine for kids 5 to 11, and we'll circle back to that because that's something we do need to communicate effectively. But as a parent, and I'm trying to keep us focused on content that parents are wrestling with as they make these decisions. So it's been widely discussed in media that the dose that is being proposed for the kids 5 to 11 is less than the dose for kids 12 and up. Now, if I have a kid who is 10 and weighs 100 pounds, and my sister has a child that's 13 or 12 and weighs 100 pounds, how do I know that it's going to work? And that kid that's 12 or 13 is getting a higher dose of the vaccine than my child, and they weigh the same. How can I be sure that this EUA vaccine that they're going to talk about this week actually will work in my 10-year-old that weighs 100 pounds?
Right. So two things I'd say on that. It's not as much weight dependent as it is immunity dependent. And what the studies show is that, well, this old information, but in general, the highest immune response in a human being is somewhere around age 9. So, and after that, it's all downhill. So that younger child just has a more robust immune response. Number two, and to me, more importantly, it's simple that the studies, so honestly, you can't know everything, but so what I look to is what we do know. And the studies were done on children 12 and up with the 100 microgram dose. Excuse me, I'm not sure if that's the dose exactly. It's 0.3 ml, so I can say that. How many micrograms? I actually have to remember. Studies were done on 12 and up with the 0.3 mLs, and on the children 5 to 11 with the 0.2 mLs. So what we know is by age in the studies, we had a robust immune response at the 0.2 mLs for 5 to 11 and a robust immune response for the 0.3 mLs ages 12 and up. So I think as a parent, I would feel confident were I the parent of the younger child, that my child will respond okay.
So does it make a difference in terms of safety that this vaccine for the 5 to 10-year-olds has only received the EUA, whereas the vaccine for 12 and up has progressed from the EUA status to full endorsement? Should I be concerned about that as a parent?
I would say maybe. I mean, being honest, but I think that in all of medicine, a number of us are physicians here. I have a quick shout out to my colleague in the NMA, Dr. Gary Dennis. Everything is benefit risk in medicine. You know, when you have a surgery, you could get a post-op infection and die, but you get the surgery because you need it. I would say, generally speaking, it's a fairly minimal concern. The vaccine has been given to overall 400 million doses in the United States. That's J&J, Pfizer, and Moderna. So we're not seeing any groundswell of these adverse events. The dose is lower, so if you're worried, you're getting only, it's half the microgram dose. And most importantly, we're in a pandemic. We just can't wait for another 6 to 12 months until this has BLA, that's a biologic licensure agreement. So the full. So no, I would say as a parent, I would ask my doctor and get an explanation. But if you are asking me, as your pediatrician, I'm also a pediatrician, I would say, I understand your question, but I would recommend your child get it. It'll be fine.
And finally, and I'll turn it over to our other moderators, what is the impact of getting children from 5 up immunized so that our population that's eligible for vaccination will now be 5 years and up? What is the impact that's going to have in terms of everyday life?
Yeah,
is it going to change what we do at home? Is it going to change what we do at school? What's it going to do?
So it should. We'll know once we start doing it, and once the ACIP votes in favor of, which has not happened yet. I'll underscore that. That's in 2 days. Again, as I spoke or referenced in my preamble, it'll get us closer to community immunity. With the pneumococcal vaccine, as children got vaccinated, we saw against a bacteria pneumococcus, we saw less adult pneumococcus. So what we will see, in my belief, is we will see less adult disease, COVID-19. If the children are fully vaccinated, general rule is if you're fully vaccinated, you don't need to quarantine if you're around somebody that is infected. So if you have a classroom full of fully vaccinated people, except one child, and that one child gets COVID, and this is a presumption that the same rule will be in place for children, you don't need to quarantine unless you're symptomatic, so the kids can stay in school. They can go around, you can feel more comfortable with them playing with other children. You can feel more comfortable at a Thanksgiving dinner, that they're not the ones spreading it to other people. So I believe that it'll make a significant difference in everyday life of that family, of these children, or that child that is now fully vaccinated, 2 doses, 3 weeks apart, and then 2 weeks after that, you're fully vaccinated.
We have a question in the chat, and I'm just going to read it. How should parents decide about vaccination with Pfizer vaccine in children that have cardiovascular issues?
So,
And I'm assuming by this question that they have a comorbid condition. Before they get the vaccine, they've got a cardiac condition.
yes, so the major concern I've been hearing is of myocarditis. So myocarditis or pericarditis, generally myocarditis, inflammation of the heart muscle, has been found in the children that are 12 to 25 or so, mostly males, like 8-to-1 male. And that is of some concern. I would have to look at that case specifically to understand what the cardiovascular concern is, and with that, make a determination. I don't believe that a cardiovascular condition is a contraindication or even a warning to get vaccinated. I don't recall that children that are at high risk, or not high risk, children that have a cardiovascular concern had a higher rate of myocarditis. I do not believe that's the case. That is something I would talk to my pediatrician about. But from my knowledge right now, I believe you're okay, but I need more information.
Now, we don't have on the table, and I did say I was going to turn it over to my partners, and I am, but we at this point still don't have any tools in the toolbox besides masks for children under the age of 5. What do you see as we go forward as a parent? That you've got a 2-year-old in the household now. What is that parent going to have to consider going forward?
First, get everyone else in the household vaccinated. So those people will be less likely to spread it to that 2-year-olds. And 2-year-olds are going to be going to daycare with other, preschool children, say 2 to 4. So the primary concern for me as a pediatrician, well, first I'd say if you get everyone vaccinated, then that's a big start. Children can get it and can spread it to each other. The studies show that children are more likely to spread it to older people than children to other children. But what I would say is I would feel comfortable, because we've had relatively little issue with children that young. I would say that if the child got URI symptoms of 4 and under, I would consider when they go to see the doctor to get a COVID test. That's a really, really tough question because children get colds all the time. I would say that I wouldn't be overly worried about it because, quite frankly, I don't know how many deaths. There probably been less than 100 deaths in children. In fact, no, there are 153 deaths in children, period. So no, they have very little to worry about. For some reason, this virus does not harm young children.
Thank you so much, Dr. Brooks. And I turn it over to Dr. Walks, who is not only one of our co-moderators, but a former public health officer, and I am sure has many thoughts on this situation that we find ourselves in.
First of all, Dr. Brooks, thank you for bringing such a high level of scholarship to the Black Health Trust. It's always much appreciated. I have one of those practical public health kinds of questions. So this is an emergency use authorization. A lot of folks don't really understand exactly what that means. And so first, I'd like you to kind of talk a little bit about what does it mean? Does that mean that there's an emergency, or it should only be used in an emergency? Why are those words being used? And then you talked about the risk benefit in medicine, which as a physician, absolutely, you always, there are no medicines with zero possibility of side effects. We know that. But since COVID-19 doesn't impact kids to the level it impacts older adults, how do parents kind of gauge that risk of I'm going to, even though it's tiny, the risk of me getting my child vaccinated versus the risk of my child getting COVID? Those are the things that I think sometimes just the regular folks are struggling with. What do the words you're using mean? And how do I figure out the risk for my kid?
All right, so, okay, and thank you for the question. So first, in terms of EUA, the emergency use authorization is granted by the FDA when they do a rapid review of the available information. Normally, I believe they would want more information over a longer period of time to make a determination whether a biological, and these are biologicals that are being reviewed specifically, would get full authorization. But good question. Is it used only in an emergency? That's a really interesting way to phrase it. I mean, that's actually a good way to phrase it, because first of all, the pandemic is an emergency. But I will note that the pandemic is slowing down. The rates of cases, hospitalizations, and deaths is trending downward. I would say we're still in an emergency, quite frankly, for a couple of reasons. One, because we don't know what new variant may show up. And we don't know what's going to happen in the wintertime when respiratory viruses tend to spread more rapidly. So it is granted emergency. So you use it because we are in an emergency, but it's more focused on the fact that it was reviewed on an emergent basis. And then over time, we'll monitor the data. And just like with the other vaccines, well, the mRNA vaccines, they receive full authorization. As it relates to why I should get my child vaccinated, first of all, the vaccines are safe and effective. So there's little downside. So the risk is minimal. And I will point this out too in terms of the myocarditis risk, which I think is, again, that's the one thing that's sticking out to me. And I think it is reasonable. The studies show that those that got myocarditis as a side effect that we believe from the vaccine had a mild myocarditis in the hospital one day, primarily because you just feel uncomfortable not hospitalizing a child with myocarditis. But the risk of myocarditis from a child that got COVID is higher than the chance of getting it from the virus, and it's more deadly. Those kids were in the hospital days and days, more likely to be in an intensive care unit and have sequelae afterward. So and we're talking about cases in the 1 in a million, but maybe 8 in a million. I can't remember the exact number, but it's not high. So the benefits are your child is not going to get COVID, has a lot lower, 90% efficacy of being sick with COVID. And again, getting back to keeping the family unit uninfected. So as a parent, I would want to talk, if I had any concerns, I'd talk to my pediatrician. And that's really, I'm going to have to underscore that. But if you're talking to one now, like me, I would say that I feel confident that your child will be okay getting the vaccine. I can't say the same thing if your child gets COVID-19, the infection.
Thank you, Dr. Brooks. I'll pass it to Dr. Hines.
So again, thank you very much, Dr. Brooks, for joining us today. I am a parent of a 6-year-old and an 8-year-old. So this is right in my wheelhouse. And to a certain extent, I have a comment, but I also have a question at the end. And I appreciate your last comments, because as you think about vaccine hazard in adults, right? And folks who are able to get themselves vaccinated, when you say that kids don't get sick quite as much, seriously sick quite as much as the adults do, having a way to phrase it and having a way to encourage people is really important. I think one of the other things that is helpful for example, for my kids is my kids have been listening to us talk about this for over a year and a half. and they interpret themselves as being vulnerable and unprotected. But you adults, you got something. You guys have a shield, right? And the kids are like, I want a shield too. Like I want my protective covering, you know, that you adults have. When's it gonna be my turn? One of the questions that I did have though is about are other developed nations, because I know that there's still some of the world isn't even on their first round, right? But are other developed nations vaccinating their younger children, these 5 to 11-year-olds and things like that too, if you know?
I don't know. That's a very good question. I believe that some are. I believe they are, but I'll have to check that. That's an excellent question. And you must have some pretty bright kids, which I'm sure you do. The way they're at a 6-year-old, a first and a third grader talking like that is pretty impressive. So yeah, I'm not sure what's happening in Western Europe or Australia, the Far East, maybe Japan. I don't. That's a great question. I think that they are in Israel, because I know we were looking at some Israeli data, but I don't recall whether that was data on studies or data on the fact that they've had use. I mean, population-wide use.
Oh, go ahead, Dr. Hines.
Well, the other question that I had was kind of a logistical question, because Pfizer has its kind of challenges when it comes to how it's stored and all the rest of that stuff. Do you think do you anticipate any issues or pushback from parents who are trying to find access and might have to go to communal resources for their vaccinations as opposed to their pediatrician's office? Do you think that might be a barrier or an issue for people?
Okay, first of all, that would absolutely be a barrier. The studies show that parents want the vaccine administered in their pediatrician's office. Okay, so good question, and that's been studied. But on the positive note, to look at that, the Pfizer half dose 0.2 ml vaccine was manufactured with a different buffer. It is stable at refrigerated temperature, 2 to 6 degrees centigrade for 10 weeks. So that is a phenomenally good thing. So, you pediatricians can now order it, store it for up to 10 weeks in your refrigerator. Once you puncture the vial, it's only good for 6 hours. So make sure you got, I guess, 10 people. I'm not even exactly sure if a vial is 10 doses now, but or 5 doses. But the storage requirements have been lessened quite a bit.
So I have a question, Dr. Brooks. I'm traveling to Washington, D.C. in another few days. I've got a newborn on the way. What is the future for vaccinating children less than 5?
Yeah, I believe that Pfizer or Moderna or both are studying 6 months to 4 years, 4 years, 11 months. So those studies have begun. And so as a pediatrician and a vaccinator, I am in favor of getting these youngest children vaccinated. And you said a newborn, Dr. Maxey. Therefore, let's hope that the mother got vaccinated. So there'll be some passive antibodies, some passive protection in that newborn if the mother is vaccinated. And as we know, the vaccine is clearly recommended for pregnant women. Pregnant women are at higher risk for an adverse outcome from COVID-19.
But for other potential grandparents, what is Tdap and why do we have to take that?
Yeah. So Tdap is the vaccine that we use against whooping cough, and add influenza in there too for pregnant women. But whooping cough is a bacterial infection that can be deadly for children. All the deaths we see from whooping cough are children generally under 2 months of age. And the antibody response to immunity wanes. So a pregnant mother or people around a child, even if they got vaccinated, their immunity may be dropping off, and they could give that child whooping cough. Pertussis is the infection. So we want to what we call cocoon a newborn, which means everybody that's around that newborn should be vaccinated against pertussis or Tdap, the Tdap vaccine. And then that child will not be exposed to pertussis and won't get it. I hospitalized a child with pertussis, and it was scary. I had a 3-year-old come in with it. This child was coughing so badly that I actually called my nurse to come in and told her to get ready to call 911. And the mother said, "I'm here to get vaccinated," because I didn't believe in him. My child just got out of the hospital and his pertussis is better. And I was looking at the worst I've ever seen a 3-year-old be, and she's saying he's better. So you don't want pertussis. So that's the Tdap vaccine.
One other question, if you just go into a little bit of depth. We talked about
Dr. Maxey, before you move to another subject, there's a question that's requesting clarification from Dr. Brooks about what he meant by passive immunity in the mother.
Oh, okay. So, yeah, okay. And thank you for the question. So what happened, passive immunity means you get antibodies in your system without getting a vaccine. So we could put immune globulin IV into you, which is done. But what happens is a mother through the placenta passes antibodies into her newborn, into her baby. So a lot of stuff comes in through the placenta, and a lot of stuff comes in through breast milk. So passive immunity means you acquire immunity without your immune system doing anything. Just someone puts antibodies into your bloodstream. That's called passive immunity.
excellent. My question is around the issue of infectivity. And we know that there have been so-called, I don't know if the word is good, breakthrough infections. Tell me about infectivity and how that interrelates with being vaccinated or not vaccinated, and why that is so important in children.
So that is crucially important. If we're talking about children, we can, but it's crucially important in adults too. So first of all, the studies show that you are 24 more times likely to be hospitalized if you get COVID and unvaccinated. So if you get COVID and you're vaccinated, you generally get a mild case. You get COVID and they're 10 times more likely to get it if you're unvaccinated. So you can get a breakthrough case, but if you're vaccinated, 10 times less likely for it to happen. So that's actually really, really important. In children, I literally read this story this morning. Fully vaccinated children are 5 times less likely to get hospitalized. And then as it relates to infectivity, those studies are not real clear yet on the 5 to 11-year-old population. But for others, 12 and up, if you're vaccinated and you get COVID, you shed the virus for less time with the Delta variant. Interestingly enough, you still have the same amount of Delta virus in your upper airway, but which is more than with the other variants. That's why it's more infectious, but you tend to shed it for less days. So vaccinating helps with every aspect of COVID. And that's one thing as I think about those children. So my doc over here with the 6 and 8-year-old, children that are vaccinated, even if they get sick, they're less likely to get long COVID. So the vaccine is kind of protective on almost every level of COVID-19 and less likely therefore in these kids to get MIS-C. So the vaccine is protective against even infectivity.
So if I've got a child, and I'll go to Dr. Waltz in a moment, if I've got a child and they start having in the 1st grade, 2nd grade, 3rd grade, apparent learning disabilities, could that potentially be related to that they might have had a subclinical case of COVID and be experienced in long haul?
Yeah, I would say there's no clear data on that. My answer would generally be no, although anything is possible. But then the statement would be, well, my child developed this learning disability. I'd say the chances of that are exceedingly low. The only thing I think of, and I hate saying things that, there's 1 in 5 million chance of people hang on to that. But we know that with long COVID, we see quote unquote brain fog, cognitive difficulties. So theoretically that child could have had, but COVID and then they got this. But the long COVID and those symptoms that are later on are generally in people that were sick with COVID. They don't have to be hospital, but simply people with asymptomatic or very, very mild COVID don't seem to get long COVID. So I'd say to that parent, no. That 6 to 7, 8-year-old, first to third grader, if there's something going on with a learning disability, you need to get an IEP and focus on whatever it is that can be done to mitigate and help that child.
Dr.
So-
Wall?
Thank you, Dr. Maxey. So Dr. Brooks, because of my public health background, I tend to be that person that kind of thinks about how things are happening in the public or on the street. It's kind of fun being the smart doctor sometimes, but it doesn't often help in those public health settings. And so I really appreciate your straight, plain talk about getting the information out. So I'm in the supermarket this morning after church, getting my booster shot. And I'm so excited to have my booster shot. And there's a woman walking down the aisle and she runs into someone she knows who doesn't have their mask on because the mask mandate has been lifted in the area where I live. And she's apologizing for wearing her mask. And I have my mask on because of so, and I don't really know how best to help folks feel comfortable. I'm as vaccinated right now as you can be. I'm going to still have my mask on. I just am, because as Mama said, when I brought those tests home, 95% is not 100%. Where's your other 5%? And so even though those of us who are fully vaccinated and have our boosters and what have you, we need to feel comfortable wearing our masks, need to feel comfortable having our children wear their masks. And so what is your message when you're talking to the public about feeling comfortable about not only getting your vaccine, but keeping whatever other protective measures you have? Stop, wash your hands, stop, there's some hand sanitizer, get some, all those kinds of things.
Right. Well, a couple of things. First of all, you're where you are because your mama was telling you 95 wasn't good enough. That's why you achieved so well. And again, here it's weird because in California, there's no issue. So in these other areas, I would say that you don't know what anyone is doing around you. You have no idea. It's like looking at someone thinking that they have HIV. That's what people used to be. So what I would say is that it's better to be safe than sorry. I would say that wearing a mask is now kind of the norm, that it is just the norm. And I would also say that, I want to protect you. Remember, most people are not wearing N95s. So as a public health officer, that wearing a regular protective surgical mask or protective mask, it blocks your secretions going to someone, but the opening is not small enough to block a viral particle getting in. So I would tell them, if you don't, I'm doing this for you. I'm wearing my mask for you. That's what I would tell them. I care about you enough to protect you from me.
Good, well said.
Well, while we're talking about that, we touched on this a little bit, but just wanted to be somewhat explicit about that. So some of the things that the little kids, in particular my little kids, don't do anymore that they used to do is like indoor playgrounds and things like that. Like, and especially as we're going into the winter months where some of your outdoor options are a little bit restricted depending on where you live. Can I feel more comfortable letting my fully vaccinated child go back to the indoor play gyms, even carpool with other parents and other kids? Because again, you don't know what anybody else is doing. Some of those types of communal activities, kids activities that we don't do anymore, even with their masks on.
Yeah, so this gets all the way back to that whole basic concept of benefit risk, because children learn socialization by doing exactly what you just said. And that's a really important part of development. Social development is crucially important. You got a really smart kid who doesn't know how to talk to people. So If you're wholly restrictive because you're really, really worried, that's a harm or a risk. So my feeling is this, and I said, these are really, really good questions. I have to add also, the toughest questions are the practical questions. Now, I can answer stuff about percentages and infectivity, but it's like, what do I do with my kid if he wants to play indoors? So I would say if they're all fully vaccinated, I would feel pretty confident letting them play. It's children, because again, they just don't tend to get sick if they get COVID. And then the general rule is if you are for adults, and this probably would be for children, if you're exposed to someone who is sick or COVID positive, but you're fully vaccinated, you don't have to quarantine. So I think that when we get a month from now or 2 months from now, when 70%, that's crossing my fingers, 70% of 5 to 11-year-olds are fully vaccinated, then I would feel pretty comfortable with having those kids play together indoors. But what's going to happen is, assuming the CDC approves it on Tuesday, we're going to get data. And that's why I spend, half hour every day reading on this stuff and looking up everything I can possibly find. So I would say, yeah, I would likely, once my kids are 2 weeks out from their second dose, I would likely say that my kid could play. I'll just say that. That's going out on a limb, quite frankly, as a pediatrician and someone who's really involved in
So in a hypothetical sense, Dr. Brooks, we know that the mRNA vaccine tend to decrease in efficacy over time. I know the data is not in yet, but is there any thought about the longevity of these pediatric vaccinations, how long they will protect our children? Where are we going in the future?
Yeah, so here's what I think that children have a more, and the studies show their antibody levels were higher than adults. In this, they compared, not even, well, the 5 to 11-year-old response was compared to 12 to 25 years. So those are still, and they were higher than that. So those 12 to 25-year-olds respond really well. So if the kids are higher, so I think that the kids' antibody levels are going to last longer than the general population of those older than 11. But my instincts tell me that we may end up having a yearly vaccine. But that is so tricky because, first of all, right now the pandemic is waning. So will we need a booster? Maybe, maybe not. We don't know how long your immunity will last after getting a booster. It started dropping off with the primary series, I'll call it now. So now that you got a boost, is the boost going to last 2-3 years or forever? We don't know. So what'll happen, and this is, I think, important for people to understand, like in this, we don't have all the answers, but just, ask me next week or next month or tomorrow, because this is playing out in real time. This is like a sporting event and you're in the third quarter and you're asking me, well, are the Rams going to win the game? Well, they're up right now, but who knows? So I'd say just stay posted.
Especially if Tom Brady's in the game. So of the moderators and Dr. Brooks, I'd like to pose a question. We all have been faced with vaccine hesitancy, and people have all kinds of reasons they don't want to get vaccinated. Now we're bringing up their kids. What are some of the approaches that we're going to recommend, or cases you've seen? How we're going to approach, you didn't want to take it, now we want to do your kids? What's going on with that? How do we handle that? Let's start off with you, Dr. Brooks.
Okay, I was leaving it open. So again, I start with, okay, the reason why people aren't getting people that are vaccine hesitant, comes down to fear. I've kind of figured that out over time. They have 100 different ways to say I'm afraid to get vaccinated, is what all that stuff is. So we have to approach it from knowing what the reason is that the person doesn't want themselves get vaccinated or their child. I always start with the vaccine is safe and effective. I really do. And then what I would say, it's going to protect your child from getting sick. Parents care about their children more than they care about themselves. I have mothers coming in mother's looking half dead, the child can't find because he's running around playing somewhere. So I would say that the vaccine is safe for you, the vaccine is safe for your child, and you don't want your child getting COVID. You don't want your child missing school. You don't want your child giving it to other people who may have gotten vaccinated or immunocompromised, or people that haven't gotten vaccinated. You know, all the Black community, you're all not getting vaccinated, then your children give it to those unvaccinated people that are around. So that, and the other thing is each case is different. So when you've seen one vaccine hesitant person, you've seen one. So you find out what their reason is, and you ask them straight up, what are you worried about? And then you respond to that.
Dr. Neighbor, Stevens?
I would concur with what Dr. Brooks just said, but I think I would circle back, and because we haven't talked a lot about this, but it really comes into play when you're discussing children and families. And that is, not only do you want to protect your child, but you're also protecting the rest of the people in your family or your contacts. And I want to emphasize this as we're going into the holiday season, where there tend to be more family gatherings or parties that are not family members. And so we want to not only in the conversation deal with the basic fears that the parents have, but also emphasize the personal responsibility to others that I fear is getting lost in our society during this period of the pandemic.
Dr. Walsh, what do you think?
I want to circle back to where I think Dr. Brooks started, which is while we're rushing to tell people that they should get vaccinated, we do have to listen. We do have to try to give someone a chance to tell us why they are hesitant or why they up to this point. And when they say, well, I'm still waiting to see, yeah, as Dr. Brooks said, that's just fear. You've seen enough at this point. So there has to be something. And there are going to be people who tell you, I don't know, I just don't feel I'm ready. And we have to be able to leave open the next conversation when something happens that allows them to be ready to hear something that we have to say. And I know personally, I get frustrated when I see one more story about someone who is on a ventilator and the family is saying, you know, they were just going to get vaccinated next week or what have you. It's challenging for those of us who have been kind of following that scientific prime directive and moving in that direction. But I think we have to be willing to listen and let folks tell us what their challenges are. And then I think Dr. Brooks said, you know, you've seen one hesitant person, you've seen one. So if you're willing to listen, then you're able to craft a message that may be relevant. The last little part I'll add is that a lot of people are getting vaccinated because there's a consequence to not getting vaccinated. And sometimes we can explore with someone, well, what happens if you don't? What about that job that is mandating a vaccine? What about being able to go to your kids' play at school? You can't go if you're not vaccinated. There's so many opportunities for us to help people think through what are the consequences of where you are right now versus where you can be.
Thank you. Dr. Hines.
I agree with everything that's been said. I think personally what I would add is I think one of the things that we saw with the original COVID vaccination and dealing with hesitancy is that space where individuals talking to their own peer groups and to their own folks and saying, I got a shot, telling your friends or your family members, I got a shot. That was very effective. I think that's probably something that we'll hopefully do as parents take their younger kids to get vaccinated. Because you also saw in the adolescent groups, they were using their individual peer engagement to encourage other teenagers and things like that to get vaccinated. 6 and 7-year-olds can't do that in the same way. But I think as parents, because parents tend to run in cohorts, right? Like you got like-minded folks on your soccer team or in whatever little groups you hang in, how you decided to be friends with this mom or whatever. So being vocal about your willingness to get your little kid, you know, the younger kids vaccinated, I think will be particularly helpful. And this is another place where, again, for example, for myself, I can say, I'm not asking you to do anything that I didn't do. Like, and we were able to do that as adults with the COVID vaccination, when we, in all of the different avenues where we've gotten up and told people to get vaccinated, we're saying that from the point of view, I too am vaccinated. I'm not telling you to take a risk that I didn't take. So I think I'm in a place where I can also say, I'm not telling you to take a risk that I didn't take. We're in that same space together.
Thank you. I know we're getting too close to the top of the hour, and I want to thank Dr. Brooks for taking his time to come to us. But I want to show a slide. So Simon, if you can show the next slide in my deck, there's a chart that I wanted to get our reactions on. And it's a chart I took from the New England Journal of Medicine. And it, go down to the next slide after that. Yeah. So this shows the variants and some of their characteristics. And starting on the left, we talk about the disease disparity, and it shows that there's an increased illness that happened with that B117. That's the original virus that came out. Then there is the beta, and it's unchanged in terms of severity. The the gamma, and then the delta, that it may be more severe. In terms of mortality, it looks like the first one is still up. It was very deadly, unchanged for the next two variants. And then the Delta variant had a more lethal effect. And the immune evasion, or not being adequately treated by the current vaccines. The original B117, for which the vaccines were developed, it wasn't evasive. The beta was quite evasive. The gamma was not, but the delta is somewhat evasive, and we don't know what's down the pipe. And the flags at the bottom show where they're from, and I didn't do very well in geography. But I'd like, as one of our final discussion points, some discussion around what you think about this and what this means for the future in terms of how these variants are going to be counteracted by these vaccines and other treatments that we have, which may not be pharmacological. Anybody want to take a stab at that?
I'll jump in and say that I think this is an incomplete chart, because it is only to respond to the question you're asking, because it only is reporting what we have seen now. What the big risk for the future is going to be is what variant is going to come. And we know that they're coming because we have too large a worldwide virus load. So as our resident virologist has taught us, viruses are going to do what they do, which is they are going to mutate. So with the viral burden worldwide that we have, it's assured that we're going to have additional viruses become, variants become dominant in the future. And so this chart sums up nicely what we have seen so far, but the real question is what's coming down the pipe.
Dr. Brooks?
So I think that, as Yogi Berra said, the hardest thing to predict is the future. So I think that there are 1,000 variants out there. They call them the ones that we're actively monitoring and ones of interest. So what we've been seeing is the vaccine has been fairly well protective against the variants that have come to pass so far, that have become the dominant. Delta was in March, I think, was 1%, and now it's like 99%. So Delta is going to probably go away. There's going to be Kappa, just saying.
Just saying.
The Kappa Alpha Psi variant. So I think that what it speaks to is we need to get vaccinated and stay vaccinated. And this is probably an argument for the fact that we may end up getting yearly vaccines. And the cool thing about mRNA is you can tailor the vaccine to the variant, just like you do influenza every year. So I think that it's a basic concept to understand. I believe that COVID-19 or SARS-CoV-2 with this variant are going to be here for a while. And quick statement, I just looked it up. So the UK will be determining probably in November this month whether to vaccinate 5 to 11-year-olds. So the EU works as a group, but that would be separate from Israel and separate from Australia. So I'm still not sure what's happening in those two environments.
Dr. Walk and Dr. Hines. And I got 2 more slides just for people to come in.
The only thing that I would add about the future is it's interesting because when you think about what variants and things that may come, we're developing treatments and things for adults, but those things will not be accessible to kids. So if anything, you could use that same argument to be a reason to get your kids vaccinated, because some of these alternative pathways that adults are choosing for themselves, like if I do get it, I'll go, I'll use X, Y, and Z. Those things aren't like, you can't do that for your kids. So the uncertainty of the future, especially in that regard, might be a way to encourage vaccination in the younger kids who have fewer treatment options.
Okay,
So
go ahead.
So I've said from the beginning that the best thing you can throw at COVID-19 is a healthy body and a good set of lungs. I think there's something that we have to continue to emphasize in addition to the vaccine. Be as healthy as you can. Do everything you can to preserve whatever. Say, well, if you're this age, you can't, the vaccine won't work as well. I know Dr. Brooks probably can't tell, but I am above the age of 9. So my immune system has had a long time to go downhill. And I think we just have to be willing to get out and exercise and eat right and get some sleep and do the things that keep our bodies able to fight whatever's coming our way. That, I think, is the best defense against the future, in addition to getting the vaccine, paying attention to the science. It doesn't take a whole lot of science to try to stay healthy. It really doesn't. It's something that we can all do to the best of our resources.
As Simon moved forward 2 slides, I got one more question for Dr. Brooks. The latest papers I read show that kids from 5 to 11 that have no comorbidities, no pre-existing, still have more illness and hospitalizations from COVID than do other children. Can you make us understand that?
Yeah, I don't think that's true. I'd be interested to see that, because the studies have shown that the children that are end up hospitalized or dying are more likely to have a comorbidity. So I would, this is not it, I'm guessing. Is this it?
No,
Yeah,
that's not it.
ivermectin. So while he's pulling up the slide, I want to say one fast thing about the variants. Variants thrive when the infection is spreading rapidly. So just by keeping the infection rate low, you're less likely to get a variant that's going to be out there and kicking butt. So again, another argument for vaccinating is less variant stimulus. But no, I mean, the information I had, Dr. Maxey, maybe next time I need to moderate and interview you since you have so much knowledge, but that you're more likely, just like adults, to have problems if you have underlying conditions. And I'm sure that I read that those children that died from COVID, they had a much higher incidence of comorbidities.
And the other thing that I would urge parents to take into consideration is that those children that did get in trouble, high among the types of comorbid conditions that were present was obesity.
Great. Well, Dr. Brooks, this has been a pleasure academically and socially for you coming and giving us such a high level of knowledge, and we certainly appreciate it. And if you can stay on a few more minutes, that would be great, but I don't want to hold you in case you've got some machines to look at. So we certainly appreciate it. Any last things you'd like to say?
No, I would say I'm happy to be in the company of so many experts. Again, I could do the moderating and ask y'all the questions. Dr. Hines, Dr. Neighbor Stevens, you, Dr. Dennis didn't say anything, but I know that he has something to say. Just didn't say it today. So I will just say that I was honored to be asked to speak. I would say that we all need to protect each other as a Black community. And we need to get the facts. You know, when you're looking for legal advice, you don't go ask your neighbor who is a plumber. Okay, so when you want health advice, you ask people who are experts in health. You got Dr. Walks here, public health. So I would say that to keep fighting the good fight. This thing is not over, but we're headed in the right direction. So just keep wholly optimistic, and this too shall pass.
Well, thank you so much. And Dr. Walks, every time I read this word, I think of you. Is that ivermectin? Is that related to Ivan? But can you go back to that slide, Simon?
Why do I have? Never mind, Dr. Maxey.
Go down to the next slide. Wait. Go back one.
Right.
Go back one. Okay, read that. It said, this is Dr. Mark said that what ultimately swayed him in the FDA approval was a third of the children hospitalized with COVID did not have identifiable risk factors, and trying to limit the higher risk groups would create issues. And
yeah. Okay. I'm right. See, so that means 2/3 did have an identifiable underlying condition, risk factor. And so, yeah. So I mean, I think that's look at the converse of what is what is there. And then the next line. I mean, for one thing that influences me more than anything, we as a people are more likely to have problems. So we need to have the highest rate of vaccination, not the lowest rate.
yeah.
Amen.
Go to the next slide. And I only like to tease Ivan because I like him so much. But I found this article saying the toxic effects from ivermectin are associated with prevention and treatment of COVID-19. And basically the Department of the Poison Center in Oregon reported that for the past 2 years, they had a call rate of 0.25. Then in the spring, it jumped to 0.87. And then just in the last month, it jumped to 21 calls for people with bad reactions to using ivermectin. And as we've talked about before, we know that ivermectin is for usually things such as, I started to say pesticides, but for things that infect the body, whether you have fungal toenails, whether you have pediculosis, which is a form of lice, whether you have parasites, and it's mainly for livestock. But people have been taking it, and a lot of the doctors that call themselves functional doctors have been pushing this and saying there's no side effects, but there are plenty of side effects that happen. And of the number of people that got hospitalized, it talked about what some of them had. Let's go to the next slide. Of the 21 people called, it listed that most of them had gastrointestinal effects. At least 6 of them were hospitalized in ICU. Nobody died, fortunately, but they had a number of major problems. So this stuff is not benign. It is not an authorized treatment, either for prevention of COVID or for the treatment of COVID. And I hardly urge everyone not to try this as something to treat. You're not a horse or a goat or a cow. At least I don't think you are. So some of these things that are just pushed and people are grabbing at straws, and those straws can get you in big trouble. We think that the best treatment is to be vaccinated. And in addition to that, what a number of our speakers have talked about is having a good, healthy body. We've recommended levels of vitamin D be normal, vitamin C, zinc, selenium. We recommended, even though most of us are not pregnant, prenatal vitamins, probiotics, prebiotics, and exercise and using common sense. So with that, we're at the close to being slightly after the top of the hour. I invite my co-moderators and Dr. Brooks in quick round robin to make a comment before we close. Dr. Snaper-Stewart.
Well, I'll use this time to remind our audience of our data, which is still troubling. The African American community represents 12% of all of the COVID cases that have occurred, but unfortunately, we represent only 10.3% of our population having achieved full vaccination. So again, we still have work to do. Let's roll up our sleeves and keep working.
Dr. Walks.
So I think one of the things we have to be prepared to do is to not let other people control the narrative by controlling the narrative ourselves. I got a call from one of the major news networks when Colin Powell died. And the question for me was, well, Dr. Walks, do you think that since Colin Powell was fully vaccinated and he died from COVID-19 complications, is this going to make hesitancy worse in the Black community? And my response was, I think exactly the opposite. I think Colin Powell was someone who had some significant health conditions and knew that the vaccine may not be as effective, but he took it anyway. This is someone who realized the vaccine was something that was an additional layer, an additional opportunity for safety. And so I think we have to be prepared when we get questions like that, where someone is going to give us a narrative and ask us to speak for the Black community. We're not one Black community. We are a lot of different individuals. And I think we have to be prepared to give a positive narrative to what's happening in our community. That's what I need to say about that.
Dr. Hines.
I think this was a really great discussion. And I think that one of the benefits of this opportunity to talk about kids and COVID vaccinations is that it also leads to an opportunity to talk about kids getting up to date on all of their vaccinations, because during the crises, a lot of people, adults and children, did not go for their routine preventative care, including, getting their childhood vaccinations and things like that, all, up to date and caught up. So I think that this is a really good time to get your kids up to date on all of flu, all of those things. And one of the things that I think that this pandemic has done is kind of increase vaccination accessibility, as far as, where you can go if it's not directly in your primary care doctor's office. And that's going to be a benefit to us all.
Good. We're going to be on every Sunday, but on the 21st of November, we're going to be hosting a special session that's going to be sponsored by Pfizer, and it's going to be on the cardiomyopathy that's caused by amyloidosis, HATTR-CM. And we're especially going to be looking for the East Coast audience that we have. We're going to have a guest speaker, Dr. Kamboyi. We're going to have a member of the NBA Hall of Fame speaking that day, and I hope our attendance can really be good for that. I want to give some flowers and kudos. One of the great honors of my life was to be elected president of the National Medical Association. But as Dr. Brooks and others on this call know, that's a long and arduous journey. And I'd like to say that if it weren't for Dr. Gary Dennis and his mentorship of me in my early years in the NMA and on the board, I would not have had that honor. And I'd like to take a minute just to say thank you to Dr. Gary Dennis. I still haven't figured out how you can be a neurosurgeon and chair of neurosurgery at a major university at age 30. I don't understand that at all. Dr. Dennis, thank you. Care to make a quick, brief comment? Can you unmute Dr. Gary Dennis? Okay, maybe he's bashful today. So as we close, Pastor Pointer, would you kindly give us our benediction?
It looks like Pastor Pointer is being distracted. Oh, there's Dr. Dennis. I don't know if we can get him unmuted. While we're waiting for Dr. Dennis to get unmuted or Pastor Pointer, let me say this, Dr. Maxey. When I took over as Chief Health Officer in Washington, D.C., one of the first people to come in and make sure that I was able to do my job and hold me accountable for doing my job was Gary Dennis. So I have much, much love and respect for Dr. Dennis, not only for his accomplishments, but for his willingness to reach out to other people and make sure that they're successful in our community. Thanks, Gary.
Okay, it's my pleasure.
Thank you. Is Pastor Pointer unmuted?
Yes, I am.
Pastor,
Yes,
would
I
love
am.
to hear your words.
Another wonderful iteration of the Black Health Trust. Dr. Brooks, we are grateful for your work and for what you have shared with us today. Thank you so much. All right, let us pray. Holy and everlasting God, our Father, maker and creator of the heavens and the earth, Jacob's God, the God of Israel. We thank you, O Lord. We thank you for your servant, Oliver Brooks. We ask you, O Lord, to continue to bless him, to keep him, to guide his work in his hands. Guide the work of the Black Health Trust. Keep us faithful and vigilant. Let us remind our people that this is not a plaything, that the circumstances that we are in are winnable, but we must deploy what you have granted unto us. Give our hands work to do, and let us live to the glory of your great name. And we'll be careful to honor, praise, and thank you. In Jesus' name, amen. It's always a blessing. Thank you, family.
Thank you. Thank you very much.
Amen.
Thank you very much, Simon Cooper, for producing our show today. Have a good day, everyone.
Thanks,
Bye.
everyone.
Bye.
Bye-bye.
Bye.
Bye.
Bye.